Yeah, so Joe's given me management of angina, which is both quite broad, but also something I think we can do quite well in 30 minutes. As Joe and Dr. Thacker said, I'm Tom. I'm one of the West Yorkshire ST6s on that programme doing research at the moment. The idea is that people chip in with some answers, so hopefully we get a bit of engagement. If not, you'll just have to listen to me, but we'll find out. We will cover what the definition of angina is, the guidelines that I would suggest you use, and then we'll do some cases as a way of covering what I suspect you already know. To be honest, none of this will be new, but it is important. So, as I say, we'll review the definition of angina, we'll review the guidelines. Hopefully you'll feel a bit more confident in first line management. I say first line because that's really all we'd expect of you at this stage. And then knowing when to refer someone to me or Joe or Dr. Thacker is very important. So if anyone would like to throw out how you would define angina, even partly, you don't have to give the full answer, would be great.
Chest pain brought on by exertion, relieved when you rest or try GTN.
That was pretty good. There you are. So that's the nice definition of angina. So chest pain by exertion, relieved by rest or GTN, as Sharon said. That was a very good answer. Within that, nice, say if you have all three, you have typical angina. If you have two of those three, you have atypical angina, which is where we sort of allow for angina equivalents, such as breathlessness and so on. If you have one or none of those, you don't have anginal chest pain, and you should think that this is not someone's heart, it's something else. Fab. So as I say, in the UK, we use NICE guidelines, though actually, realistically, the ESC, so the European Society of Cardiology guidelines, are often better and more comprehensive. If you were interested, those are the guidelines that you can use. What are the key points in history? So this is, I suppose, more broadly in a chest pain history, and you're trying to decide. So Sharon's already given us a clue as to what angina is, but what are you asking someone who says they've got chest pain?
You would want to know the onset, how long it lasts when it comes on, if there's any other triggers, if there's any other associated symptoms whenever it comes on. And I suppose in terms of past medical history, to see if there's any risk factors for cardiac chest pain.
Yeah, good. Thanks, Florian. You've all taken lots of chest pain histories, I'm sure. So location, onset, relieving factors, risk factors, just like Florence said. This stuff is not rocket science. The key things, I suppose, that you specifically want to ask is have they having rest pain? If you're having pain at rest, that then falls outside of the remit of stable angina, potentially into heart attack or into other causes of chest pain, of course. But angina should be exertional, as we've said. And is it lasting longer than 15 minutes? Again, as we've said, it should relieve within 5 minutes of rest or with GTN. So they're important questions to consider. Not a trick question. Initial investigations of someone, let's say you're in A&E at the moment, what investigations are you going to ask for if somebody gives you a typical history of angina?
Maybe an ECG and a troponin.
Yeah, perfect. That was very easy, wasn't it? I put bloods as appropriate because I think, not to get too philosophical, as a profession, we've got into the habit of requesting all bloods in everyone, but you know, you don't need to. So for example, a troponin is an interesting one. If somebody has exertional only chest pain, they're not in pain at that point in time, a troponin is unlikely to be helpful. If they have a cough and fever as well, a CRP is maybe going to be helpful because actually that might point you down a different path. So yeah, ECG and bloods are a reasonable starting point. Beyond that, you are probably not going to be requesting many tests, and that's because beyond those two tests, it becomes imaging or invasive tests for these people, and that's going to come from ourselves or you if you're on a cardiology job potentially, but overseen by somebody more senior. NICE guidelines currently recommend the CT angiogram as the first line test. Unless they've got prior coronary artery disease, and they suggest a functional test, so stress echo or stress MRI, which is a contentious point. Not everybody necessarily agrees with that, but that is what NICE guidelines say. So you have done all of that, and you have decided this person has got stable angina. What is the general management going to be of everybody who falls within that?
Yeah, someone's put down lifestyle advice or conservative advice.
Yeah, never a wrong answer. So stop smoking, exercise. Obviously, it depends on what is bringing on their pain. Exercise is important for someone with heart disease, but also you don't want to bring on the pain. So, but yeah, lifestyle advice. Yeah. Anything else? So I've gone with GTN, which we all know, I'm sure. Everybody who has got angina should get a GTN spray and should be told how to use it. What are you going to warn someone of the first time they use their GTN spray? Of a particular side effect that people end up in A&E with, but is not particularly concerning given what we know.
Is it a headache?
Headache, exactly, yeah. So GTN will relieve your chest pain by dilating your coronary arteries. It will also dilate other arteries and cause your blood pressure to drop. So you might get a headache, or it's not uncommon for people to take it and pass out. I'm not saying they shouldn't come into hospital and they shouldn't be checked out, but if the history adds up to, I took my GTN, I felt dizzy and I passed out, you know what's happened. You don't necessarily need to investigate this person extensively. NICE guidelines do not say to give everybody an aspirin and a statin. They are a bit more around and about than that. But realistically, if you think this person's got coronary artery disease causing angina, they should be on an aspirin and a statin. And if they've got high blood pressure, they should have their blood pressure managed as per guidelines. So those things are pretty simple for everyone. And then depending on the trust you're in and local policy, most of these people should then be referred to rapid access chest pain clinic to be seen by a cardiologist, and that should be within 2 weeks, or the trust gets fined. And that is to, decide A, is this definitely angina, and B, do we need to do any more tests? So third line isn't the first question I'm going to ask. Obviously, I'm going to ask first and second before. So if you are in rapid access chest pain clinic and you're seeing your own patient, does anybody know what a first line anti-anginal would be? So not sublingual nitrates, that doesn't count. So tablet-based anti-anginals. Does anyone know a reasonable first line choice? Not Florin or Sharon or Maya, because they've already answered. So there's other people on the call. Anyone want to have a shout? So if you were going to go by NICE, a beta blocker or a calcium channel blocker, I'll just put a second line up. So second line is a beta blocker or a calcium channel blocker. It's really not difficult. The things to be wary of, I suppose, are that is any calcium channel blocker. Obviously, some calcium channel blockers, namely diltiazem and verapamil, are rate limiting and should not be given with a beta blocker. So you can give diltiazem or verapamil as a first line agent, but if you do, you can't then give a rate limiting beta blocker like bisoprolol as the second line. So personally, in my practice, I give a beta blocker first, unless their heart rate would prevent that. Obviously, if their heart rate's 40, you're not going to give them a beta blocker. And then amlodipine as a second line, and then you can do both very easily. And most people give bisoprolol as a first line. It's once a day, and it's widely used, but you don't have to. You can give others, nibivolol, carvedilol, whatever you like. Third line, this is again going from NICE guidelines, not necessarily prevailing practice. NICE would suggest that you can give a third line anti-anginal. They're the third line ones they suggest. So isosorbide, ranolazine, nicorandil, ibabradine. But they would only suggest giving those if either revascularization is planned or revascularization is not possible. So what that's saying is broadly that if somebody has angina, up to 2 tablets is reasonable. If their pain then goes completely, leave them alone. If their pain doesn't, you should then be thinking about PCI bypass surgery, potentially, depending on their anatomy. We used to do a lot more PCI and a lot more bypass surgery in angina patients because we thought it helped. And it does help. It helps with symptoms, but it doesn't make them live any longer. And it doesn't make the heart work any better. So given the cost and risks of PCI and bypass surgery, it's now not given as a first-line treatment. It's down the line. You, again, obviously at your stage won't be necessarily involved with that third line part, but it's worth knowing that, that its tablets are first and second line before we think about anything more. So again, if people can chip in, it'd be great. We'll do some cases. None of this is trying to trick you, and certainly a couple of them are very easy, I think. So you're the F2 in A&E, and you've got a 65-year-old man who's got diabetes and smokes, who takes no medications, and he comes in with exertional chest tightness that's relieved by rest within 5 minutes. He has had it for about 6 months. He's busy and therefore didn't think to come in sooner. His obs are completely normal. So we've said it already. So what tests are we going to do? We're going to do an ECG. That's his ECG, and we're going to do some baseline bloods. Would anyone possibly like to suggest what this man's diagnosis might be?
Stable angina?
Very good. Yes, he has got stable angina. He ticks all the boxes. He's got risk factors. He's got a normal ECG. So he's got stable angina. So he is on no medications. What are we going to give him?
GTN and some aspirin and a beta blocker.
Thank you, Alice. So yeah, there you go. That's all very reasonable. So he has got stable angina. He's got no contraindication to any of the above. So we'll treat him as per what we've just covered. After that, we will discharge him. So you may know this, you may not know it, but just because he's got chest pain, he doesn't need to come into hospital. He hasn't got it at that point in time. He's got stable angina that he's had for 6 months. I say that just because we get a lot of referrals for people like this in the hospital, but it's why rapid exercise chest pain exists. So you can discharge him to come back within 2 weeks to see a cardiologist. Obviously, you would always safety net these people if they get rest pain, etc. And the initial test is going to be a CT. He's got no reason not to have a CT with that. Good, yeah. So the next one, you're the F2 in general practice, and you've got a 34-year-old woman who's got no past medical history. She just takes the pill, and she's come in with central chest pain, which is rest and exertion, and she's had it for a week, and she feels a bit breathless. And there, her obs, heart rate's 120, blood pressure's fine, SATs are borderline fine. So you're in GP. I don't know how many of you have done GP, admittedly, but what can you do in GP? What test could you do for this lady? Not much, admittedly. Could do an ECG. So that's her ECG. Does anybody have any thoughts as to whether this lady has angina, whether she's having a heart attack, whether she's got anything else going on? So, Jack, sorry, I've not had the chat up, but I'll come back to other questions. So want to exclude PA, good, Jack, yeah, thank you. So we don't know what this woman's diagnosis is at this point in time because all we have is an ECG showing sinus tachycardia, but she is young, she has got chest pain with breathlessness, and she is on the pill. Whether or not she had a swollen ankle, the worry should be whether she's got PE. The chance that she has angina, well, she doesn't have typical angina because she doesn't tick the 3 boxes for it. It would be vanishingly unlikely that she's got significant coronary disease at her age with no risk factors. So the next step for her should be, depending on local processes, getting her to ambulatory care. Yeah, Jack, getting her to SDEC or ED, depending on which can be quickest or the delay for each, really. If she did have a unilateral swollen calf that was red and tender, and you had it available in GP, it would probably be reasonable to give her a dose of low molecular weight heparin. Yeah, so good. Next case. So you're on the ward now, and you've been asked to see an 80-year-old man by the nurse staff because he's complaining of chest pain. He's a social admission waiting a community bed. He's got blood pressure and gout, and he's on those tablets there, ACE inhibitor, beta blocker, aspirin, allopurinol. When you speak to him, he says he has chest pain when he walks to the toilet, goes away when he's on the toilet, walks back to his bed, gets it again, goes away when he sits in his bed. He's never had it before. He feels a bit breathless. His heart rate's 100, his blood pressure's 100/60, and his SATs are 99%. Fortunately, he had an ECG and blood tests done 24 hours ago. Any abnormalities people would throw out or suggest from his ECG or from his blood tests?
He's anemic with that low HB.
Good, yeah. So he's got low HB, 85. You probably see 85 on the wards a lot of the time without necessarily batting an eyelid, but in this context, it's probably going to be quite relevant. What about his ECG? Carl, sorry, has said T-wave inversion V1 to V4, good. So he's got ECG changes and he's got a low HB and he's got angina. So what's his diagnosis? Does he have angina? Does he not have angina? So Jack has said compare it with the previous ECG. That's never the incorrect answer. So you should always look at previous ECGs. He may have had T-wave inversion for 20 years. In this instance, let's say it's new. So Carl has said that he may have angina secondary to his low HB. Kudzia has said posterior MI or early signs of MI. Yeah. So he's got ECG changes, he's had chest pain. In theory, he could be having a heart attack, quite right. What I was getting at least was, as Carl says, he's got angina secondary to his anemia. We haven't got time in 30 minutes to really go into depth about this, but angina is a symptom. Those 3 definitions of angina, none of them say occlusive coronary disease, atherosclerosis, etc. So angina is a symptom. This man does have typical angina, but it's not because of coronary disease. His is because of anemia. Given that, how would you want to manage this man? Yep, Aisha and Kudzia. So group and say cross-match transfusion, very good. So I've said urgent transfusion because depending who you speak to, transfusions are a daytime task. And that's because of the risks of transfusion, and that generally transfusions don't need to be done at night if it's just for chronic low HB without any symptoms. What this man has is symptomatic angina with ECG changes secondary to his HB drop. That's because he's not getting enough oxygen to his heart. So he should be transfused overnight, Sunday, whatever, whenever it is, but not so urgently that you need to give him an O-neg transfusion. He can be cross-matched as long as he's not hosing out. He was on aspirin, so obviously we should stop that. This is not because of coronary disease. This is because of bleeding potentially. His blood pressure was only 100. I think we probably should hold his beta blocker and his ACE inhibitor. And he obviously should not be given any anti-anginals. The temptation would be to say, well, he's got angina, therefore we go down the management we've just discussed. But this is just a very different case, obviously. Yeah, Jack said he's hypertensive, so not for GTN, exactly, yeah. So you're on F2 in GP for the next case, and you have got a 58-year-old man who's already had a heart attack. He's on insulin for his diabetes, he's hypertensive, he's a smoker. He's on the normal host of medications that people are on after an MI, plus insulin, obviously. He has got 3 months of daily exertional breathlessness. He uses his GTN some of the time, but usually rest is adequate to relieve it. And is obsifine, sorry. His ECG looks like that. If anyone has any thoughts on his ECG, that would be great. Yeah, left bundle, good. So he's got a left bundle ECG. He's having breathlessness on exertion that goes away with GTN. So he isn't typical angina, but given his history, you probably wouldn't want to definitively say he doesn't have an angina equivalent or atypical angina, especially because he's got insulin-treated diabetes. So we do know that these people can sometimes not have chest pain in the same sense. What would you do with this guy? So you're in GP with him. So I would refer him to rapid access chest pain. I would safely net him. He's only getting exertional symptoms. If he starts getting rest symptoms, he needs to go to A&E, probably quite urgently. And you could consider another medication. I don't actually know whether GPs would prescribe a third line without asking first, but you could always ring the on-call and ask if you're not sure. Again, he is going to be seen in rapid access chest pain. It wouldn't be unreasonable to try and relieve his pain in the meantime. Jack has said likelihood would probably be ED. Yeah, that's a tricky one. He's had, I think I said 3 months. He's had 3 months of symptoms, so it's relatively stable at this point. You're not wrong in saying that he might need to go to A&E if you're very worried about him, especially if he lives alone, if he's older, etc. Like I say, rapid access chest pain, you should be seen within 2 weeks. So it is a quick way, or SDEC maybe. A&E, certainly at Pinderfields and maybe at other places, the waits are ridiculous, and we should be trying to avoid A&E at all costs, I think. I'm just being told by Joe that we need to wrap up. So, through case 5. As I said, I don't think I've given you much new information in this, but that wasn't really what I was trying to do. I suppose what I would try and say is not all chest pain is angina and not all angina is chest pain. It's getting a feeling, basing it on individual risk and so on. Who to refer is tricky. You don't want to over-refer and send everyone, because that then just clogs the system, and the people who really need to be seen get seen slower. But you don't want to be the person who doesn't send people in. Again, that's just something that comes with experience. When you're more junior, you will inherently refer more, and that's fair enough. NICE guidelines are actually pretty good for angina. I say that because most NICE guidelines I'm not a particular fan of. The angina one's quite good. You can find them by Googling them very easily. Questions are apparently coming at the end. So thank you everyone for chipping in with answers, and I will hand back over to Joe.